Hypothyroidism. Hypothyroidism is difficult to treat preoperatively in the patient with ischemic heart disease because thyroid replacement may precipitate ischemic symptoms. It may be present more often than realized in patients taking thyroid hormone replacement. One study showed a significantly greater operative mortality in patients taking thyroxine preoperatively, perhaps for this reason. Nonetheless, cardiac surgery is well tolerated in most patients with mild to moderate hypothyroidism. Serum total and free triiodthyronine are significantly reduced after both on and off pump surgery and remain low for up to 6 days, whereas thyroxine is low immediately after surgery but remains to normal within 24 hours. There is some evidence that patients with low T3 levels preoperatively are more prone to the non-thyroidal illness syndrome and to a low cardiac output state after surgery. Furthermore, a prolonged reduction in the conversion of T4 to T3 may account for the slower recovery of some patients after surgery. Patients with non-thyroidal illness syndrome may not feel that well, but there is generally little physiologic impact on cardiac function. Patients with true hypothyroidism may be somewhat lethargic and hypotensive from decreased myocardial contractility and bradycardia. They may occasionally have difficulty weaning from the ventilation. Treatment. Should post-cardiotomy ventricular dysfunction occur, triiodthyronine in a dose of 10-20 nanogram can be given in conjunctive with an inotrope such as minorenone or inamrinone, which don't depend on beta receptors for their action. For the hypothyroid patient who has tolerated surgery uneventfully, treatment is initiated postoperatively with levothyroxine 50 nanogram per ounce and subsequently increased depending on TSH and T4 levels. If the patient is unable to take oral medications, one half of the oral dose can be given intravenously. If the patient is severely hypothyroid, consultation with an endocrinologist is imperative. Doses of T4 that have been recommended include an initial IV dose of 0.4 mg followed by 3 days of 0.1, 0.2 mg IV daily, and then a maintenance dose of 50 nanogram per ounce. Adrenal insufficiency. Adrenal insufficiency is a rare complication of cardiac surgery that may result from adrenal hemorrhage associated with hypertension or other anticoagulation and the hormonal stress response in an elderly patient. Manifestations include flank pain, non-specific gastrointestinal complaints, anorexia, nausea, vomiting, ileus, abdominal pain or distension, fever, and delirium. Late signs include hyperkalemia, hyponatremia, and hypotension with poor response to vasopressors. The clinical scenario can be confused with sepsis. Diagnosis is confirmed by a low serum cortisol level and failure of cortisol levels to rise 1 hour after 0.25 mg IV dose of cosintropin, synthetic adenocorticotropin hormone analog. The level should rise fourfold or to a level greater than 20 nanogram milliliter. Treatment is with 100 mg of hydrocortisone IV every 8 hours along with administration of glucose and normal saline. If an additional mineralocorticoid is needed, fludrocortisone 0.05, 0.2 mg can be given. Pituitary abnormalities, pituitary apoplexy etiology. This rare phenomenon results from infarction of a pituitary tumor due to ischemia, edema, or hemorrhage. The risk is exacerbated by use of cardiopulmonary bypass with heparinization and reduced cerebral blood flow. If the patient has a pituitary adenoma, off-pump surgery should be considered. Compression of the optic chiasm and paracellular structures results in ophthalmoplegia, a third nerve palsy, visual loss, and headache. An adjacent crisis may be precipitated by the hypopituitarism. Treatment. decrease intracerebral edema with hyperventilation, mannitol and steroids, dexamethasone 10 mg. Urgent hypophysiectomy if no improvement. Diabetes insipidus is a rare complication of cardiac surgery caused by diminished production of antidiuretic hormone. It has been noted in patients with taking lithium preoperatively for depression. The presence of polyuria, a urine osmolarity of 100 milliosmolar liter, and hypernatremia should raise suspicion of the diagnosis. Treatment of central diabetes insipidus involves use of desmopressin administered either intranasally 1-2 sprays at bedtime or 0.04 mg per dose. This is not effective in nephrogenic diabetes insipidus, which is usually treated with non-hormonal treatment therapy.